everyone. It's really a great pleasure to be here today and really to present our project. So we are the OncoLink GPT, and my name is Inês Silva. I'm a medical oncologist from Australia.
I'm Molly Lee from Hong Kong. I'm also a medical oncologist. Nice to meet everyone.
Nice to meet you. I'm Young-Sen Kim from South Korea. I'm a medical oncologist.
I'm Yuani Lim from Malaysia. I'm clinical oncologist. And I would like to introduce our coach, Dr. Roselle from Philippines. So our focus for this project is what is the most effective model for training of general practitioners in low-resource setting to decrease the time to cancer diagnosis. So breaking news, when the king cancer was caught early, that's not the case in his subjects. And the situation is even more complicated in LMIC. Delay in cancer diagnosis is very common here. So our vision is timely cancer diagnosis and management in LMIC. We are planning to propose a project based on the situation in Sarawak, because Sarawak is having just one cancer center located in Kuching. Located in Kuching, which covers up till the north more than 800 kilometers, 10 hours driving journey. And we are covering 2.4 million population. 75% of the population is relying on public health. We also plan to propose a project starting from breast cancer, because breast cancer, if we detect early, we can tremendously improve the survival. So our focus is GP, patient navigators, surgeons, and oncologists. We are also pulling in Ministry of Health, medical societies, NGOs, local government, media, and hospitals. And I believe this can be replicated in other countries. So to understand the unmet need, we have conducted several interviews with the family physician in Malaysia and in Onco, Hong Kong. And we also interviewed our head of oncology service in Sarawak. So we are also looking at what are the available resources in Malaysia that we can cooperate with. So we have Cancer Research Malaysia, and we have the UMMC team. Yang Sing will tell us more about unmet needs.
Yes, thank you. So our interview is a very precious time to understand that the current unmet needs in low and middle-income countries. So it identified several issues. So first is healthcare system factors, unclear referral pathways, and lack of resources. And as a patient factors is a long time to travel distance and time, and patient awareness is a big problems. And third is patient factors is GP awareness, high workload. It's hard to catch up all the up-to-date cancer screening guidelines, and poor communication between GP and specialists. All this together leads to delays in diagnosis and treatment. Our team is we are focused on 4 elements. It's unclear referral pathway, patient, GP awareness, and the workload. Also poor communication between GP and specialist. The current reality, I like this cartoon, is the path to the reaching out to the specialist is complex, confusing, very slow. Our team aimed to change these situations. We also discovered the existing resources and good partners who are willing to collaborate with us. For example, the Malaysia Sarawak Hospital units working at is now going to has partner with the ASCO to conduct several international cancer care programs. Additionally, Living Cancer Project team has been educating GP for several years. So we are deeply inspired by the dedication of a lot of cancer care professionals working so hard to improve cancer care in their countries. So I believe that this kind of commitment, we could improve our cancer care through education and collaborations. Another important resource is the patient navigation program. I'd like to talk more about patient navigation program. It's a big interaction between a navigator and patient. Look at these pictures. So it's designed to help the patient support through their journey. So patient navigator explain treatment option to the patient and to help the patient to coordinate appointments and connect them with available resources and provide emotional support. So these times is the patient navigation programs currently implemented at the hospital level after diagnosis, but I think our team think it needs to be expanded to the GP level before diagnosis. So Molly is going to talk about our mission.
Thank you, Yang. So after interviewing all the relevant parties, understanding the unmet need and existing resources, I think we should focus on, first of all, increasing awareness, because the screening rate and also the presentation is often delayed in LMIC. Second is also to improve the communication between GP and specialists such as surgeons and oncologists. Thirdly is also to improve the referral pathway, which Yang has already covered. So with such, we set forth 3 missions of our project. First is to empower GP of the knowledge of cancer. Second is to implement the patient navigation system into our model, which is already running in Sarawak for some time with Cancer Research Malaysia. And the third one is to connect GP with the relevant oncology specialists through MDT approach to simplify the referral pathway as well as reduce the referral time and to see the consultation. So with such, we want to achieve this by building a GP training model which contains 3 independent components, but every one of them linked up by a patient navigator. So to start off with, this training model would be a 1-year program. Okay, so it starts with a 2-day in-person meeting where the relevant parties, including GPs and patient navigator and specialists, will come together and discuss the program. This will be followed by monthly multidisciplinary meetings that will be organized virtually. And lastly, after the 1-year program, we will also gather again together to discuss and reflect on what we have achieved and can further improve for the further development of the model. The target audience would include general practitioners, nurse and patient navigators, of course, but also specialists, oncologists, breast surgeons, as well as people from the allied health. The 2-day in-person meeting will first start out with a team building with the aim to enhance the communication between GP and specialists, which is often lacked in a LMIC setting. And after which, in the second day, we will discuss and build and consolidate the 3 concepts of the program, how we are going to execute the model. And as such, we would also like to define the impact measures that will be measured in the end of the program. So now we go through the training model component one by one. The first one will be a checklist. First of all, is the aim of the checklist is to enhance the awareness of both patient as well as GP. So this is just one example that we have where we have listed it, which contains risk factors for screening as well as red flag symptoms. But this will be discussed and determined in the first 2-day meeting before the MDT, before the 1-year training model. And after, these checklists will be provided to the patient in the general clinic. And then if they have positive red flag signs that are catched on by the checklist, they will be referred to patient navigator for follow-up. And then I will hand on to Ines to talk about the MDT and the referral pathway.
the second key component is a multidisciplinary team meeting. So the idea is really to improve the communication between specialists, so medical oncologists, surgeons, and general practitioners. So even though I'm showing a table here, in fact, there are 10 monthly virtual MDTs. So the idea is to have the GPs leading those MDTs. So and the idea is really to rotate between different GP practices to give the opportunity for them to really lead and take the lead on that. But as Molly mentioned, also patient navigators are key. They are the ones scheduling and organizing those MDTs. Those MDTs also include nurses, medical oncologists, breast surgeons, and allied health people. But the most important and key feature of these MDTs is that it is patient-centered. So how exactly does it work? So each GP practice will identify cases and will present cases based on a clinical challenge or educational, for example. And then we'll send the case to the patient navigator who will combine, who will coordinate and organize and schedule those MDTs. Also, the patient navigator is in charge of taking the minutes and then send to everyone for review. So let's look more carefully to this MDT structure. It has 3 components. So the first part, case discussion, as I explained before, GP identifies the cases, presents based on the clinical challenge or education. Then we have a second part that is educational module. And as Molly mentioned, in the first weekend of our program, in fact, the idea is to give the opportunity to the group to identify the top 10 modules that they want to be seen covered during the year program. 1 educational module per virtual MDT. And then the third part is to give some 10 minutes for discussion of logistics. See this as a dynamic program. So the idea is to improve as we go with the program. Now, the third component is referral pathway. We want to make it faster. So this is the current model. The GP writes the referral letter, but as we are all aware, there are some delays. Sometimes the patients don't have the right tests or exams done on time for the appointment, or there are some delays booking the appointment with the specialist. So here is our proposed model. So the GP writes the referral letter, but then also the patient will give consent to be guided by the patient navigator. And the patient navigator will be key, in fact, really follow up the case, meaning that we'll help the patient, making sure that the required tests and exams are done on time, but also make sure that the appointment with the specialist is booked. So now we are towards the end of our program, the second in-person meeting, so 2 days at the end. So on day 1, we'll give the opportunity for the GP practices to really present and share their experience, impact, but also limitations, what they found during the year program. And on day 2, then the idea is really an open discussion in terms of presenting the proposed solutions for the issues identified and next steps. So the beauty of this program is that, as you know now, we have 3 key independent components. So they are really related by the patient navigator system, but they are independent, meaning that if we have a specific region that we can only apply the checklist, it's already impactful. But we really believe that if we have the 3 components together with the key help of the patient navigation, we really think that the impact will be much higher than the sum of individual parts. So here is the impact we think we can make. So this is the current system, and we believe that by adding each of the key components we have in our proposed model, such as the checklist, the MDT, and the referral pathway, with a very important help from the patient navigation, we can really make a huge impact by reducing the time to cancer diagnosis, but also by reducing the treatment time. And this is our vision. As Yang mentioned, this is the current reality and our goal, and we believe that with our model, we are going to make it simpler, smoother, and faster, which is going to be very important for patients and health practitioners. So During this year, in fact, we have already established very important collaborations. So this is with the Cancer Research Malaysia, and as you can see, we have our team member, Uni, already standing by the team on the ground. So this is already established collaboration. And how important is this? So since they have started already phase 1 and 2, and now they are expanding to the other areas of Sarawak, so in fact, they are very happy to collaborate with us, providing support and providing the patient navigators for our program. So that is already covered. Now, we have an ask for ASCO. It would be great to have ASCO support to really build and implement this leadership and team building training program with our team, OncoLink GPT, for Malaysia and beyond. This is just the pilot study. We really believe that if we join forces, so together with ASCO, we'll really make this very important link between oncologists and GPs so we can make a global impact. Thank you so much for your attention, and we are happy to take questions.
Comments, questions, please.
It is really phenomenal program. Yeah, outstanding presentation as well. Two levels question. The first is the local hospitals. Sometimes they lack of imaging and pathology support, and if they give you some information but not satisfied enough for your multidisciplinary program, how you handle that, because that could relate with some time wasting and factors related with it. The second is, of course, that also heavily depend on IT support. Yeah, the IT support, needless to say, we have to consider confidentiality issues, how you protect that. Yeah, but this overall is outstanding. Yeah.
Yeah. So we have been conducted this MDT across Sarawak, across the hospitals. So we already have a hybrid system, which the district hospital can share their images during the MDTs. Yeah.
Regarding, thank you for the question. Regarding the support from the radiologists and pathologists, we believe that this is exactly why there is some delay in the referral that is present. Because when these cases, they finally wait till they can see an oncologist, a lot of times these key investigations are not ready. Therefore, thereby further delaying the treatment as well as the staging for the patient. And hope we have, when we have established this MDT with the help of the patient navigator, it will be a good resource for us to check that these investigations will be available. Then we can discuss in the MDT and fasten the referral doing a pre-screening stage before they see the doctor. So hope that this actually can help with this problem.
I just want to add one thing. I think this is a very important point. So with this program, we know we won't be able to fix every single thing, but I think if we can start and give the first steps will be very important. The 10 minutes in each MDT to discuss logistics exactly for that. So I think if we can start streamlining the process and then start identify, okay, the next issue is this, so we can target the next issue. But thank you so much for highlighting a very important issue.
That's what it looks like on the picture. Is that correct?
All right. So I'll start. Yeah. This model is flexible, so it can be adapted to the local needs. So for Sarawak, we have a tertiary hospital, and we have district hospital who is capturing the patient's referral from the primary care. So there is 2 levels. So we need to connect all the district hospital doctors and the GP in the team building program. And hopefully by building up the trust and the connection, things can be smoothened.
So that leads to my second extremely difficult. They're very busy. They actually don't see cancer. They get 2 or 3 cancers a year. They get hundreds of cardiovascular, hundreds of neurology problems, and actually motivating them to want to participate in a cancer program is a big challenge. And you've set them up to do something every month for a year, as well as a pre and post. Have you tested it yet to see about the engagement of general practitioners in Sarawak?
All right. So for our system, we have the government system. We have healthcare clinics. We have around 200 healthcare clinics under the Ministry of Health in Sarawak. So they are led by family physicians. Yeah, so one family physicians will cover several healthcare clinics. So the GPs here in Sarawak is more related to family physicians. So we have talked to the family physicians in Malaysia, and they are kind of interested because they know they are lacking of this part of knowledge. Yeah.
Yes, so during interview processes, you interviewed several GPs actually, and also a lot of GPs are quite interested in this program. So also they need some help because it's a lot of workload. So we handled this situation very efficient way. So GPs wants to make some relationship connecting that with a specialist. So they just have a few cases, but they find out some cases, but they don't know how to handle the next step. So because we're going to handle this situation with help with cancer navigators, so I think it's a very important part of the model.
I just want to address the second question, the numbers. So that's a very important point that was in fact highlighted yesterday. So the number of new cases of breast cancer new cases in Malaysia is above 8,000. Of course, what specifically this pilot study is in a specific region of Malaysia. I think there are a few things to understand here. We don't know in Malaysia the percentage of cases that are cancer cases in GPs. We know the numbers in Australia, but we don't know the numbers in Malaysia. That's the first thing. Second thing is I think there are different realities. So in Malaysia, we don't have a proper screening program implemented, so which makes me think that our team think that the GPs have a more probably important role here. And I agree. I think the numbers, if we go with numbers now, and could be an impact measure, in fact, the numbers now will be much lower than I would expect later after implementing this program.
Congratulations on this, great presentation. And, what is very clear to me from looking at your model is that the patient navigator is an integral piece. And I just wondered whether you had thought through where would your source for this patient navigators be, and where they're going to come from, how they're going to fund it. Is it going to be something that the ministry pushes forward? Because I think that's important, and, because it's not an established sort of discipline yet, I think, not in all parts of Asia.
Yes. So for Malaysia, for our Sarawak, the good news is Cancer Research Malaysia and NGOs, they are supporting this patient navigator system. They actually throughout Malaysia, and in Sarawak, they have base in our oncology clinic and also in breast clinic in the hospital for the past 2 years. And they just signed the MOU to expand to another 3 hospitals in the northern part and the central of Sarawak. So they are looking into expansion by the end of this year. So they are employing the patient navigator. They have a good training system, established training system to train the patient navigator. The one thing is, at this moment, they only focus in breast cancer in Malaysia. Yeah. So, but this can be expanded. We hope this thing can be expanded further by pulling in others NGOs and also the governments.
Firstly, hi, lovely to see you again. Secondly, what does success look like? What have you measured before? What have you measured beforehand? Have you measured beforehand? What measurements are? Because I'm delighted that NGOs are willing to help, but they will want to see some outcomes for their dollars.
So for this model, we plan to have actually the definition of the impact measure is planned to be really determined and discussed in the 2-day meeting that will be followed by the 1-year program. But what we propose is that we are looking forward to a short-term measurement, which is the screening compliance and the feedback from GPs, which is more of a qualitative base. And for the long term, we want to really see the referral to the consultation as well as the treatment time to be shortened compared to the historical control, which is more of a quantitative measure. And would like to raise a fact that is that a lot of time we spend in our project is the discussion with Cancer Research Malaysia throughout the year, because they actually had they are expanding quite well, and through in the inpatient, in the post-diagnosis setting, they have actually recruited and helped around 4,000 breast cancer patients, in fact, in 4 centers. So, and they also have shown that there is reduction in the treatment initiation time, reduction in biopsy time, and reduction in the surgery time, as well as increased compliance in the neoadjuvant chemotherapy. So they did well in this regard, and actually also obtained government support. That's why government is willing to support them for the promotion of further development. And when we propose this, when we hand in this proposal to discuss with Cancer Research Malaysia, they are quite keen to actually to further expand this to the pre-diagnosis, which is the GP setting, and also is very keen to have collaboration with ESCO, which is more of a global impactful society. So I think that builds the foundation of our model, and also why we start our project in Sarawak as well as in breast cancer based on these existing resources.
Okay. Okay. So congratulations again. So you have my brain churning. So I have, which is dangerous, so I'm sorry. So just a couple thoughts. Have you considered, so part of the issues and the challenges, with putting together a model is the patient. You mentioned the patient navigator, and is very nicely outlined even in this article that you submitted as a literacy campaign. We have it in the U.S., right? There's misinformation out there, and you need to draw the patient in before you can get them referred. So had you considered at all a literacy campaign that would be embedded in this training program? The second thought was playing on the egos of doctors, quite frankly. And have you thought about designating, if you will, a GP champion? So you have a physician champion who then could train the trainer. So he or she could pass that information on to not only other physicians, but with their staff. Because oftentimes what I find is that patients will tell more to the nurses than they may the doctor. And so just to start that process, I know that there was a breast cancer lumps, and I couldn't read it, sorry, because my vision isn't all that great anymore. But I'm just thinking that, if you have this train the trainer and then they can train their staff, that would be a good way to get that person involved. So those are just a couple thoughts.
They're great thoughts. So we didn't think about the campaign, but I think that's a great idea. Can I just but then the other, regarding the GP champion, I think that's also a very good idea. The idea to have the 2 days in-person meeting in the beginning, in fact, is really to give the opportunity. So there are 2 key components of that. So is to put the team together that normally are not together, but to make them really give their input in the 3 components. For example, when Molly presented the checklist, that's just a model. The idea is for them to really change that checklist according to what they think is the best for their population. The same with the MDT. This was just a model of a structure. If they think that should be different. So if they think that we should have a specific GP has like the lead, I think that's a great. So all that is to be, we don't want to be really strict. The idea is to just be the supporters for them to grow. Yeah, sorry.
Thanks, Ines. So, regarding the patient navigator parts, and also can we replicate the similar program in future? Actually, in privately, I have talked to the Cancer Research Malaysia team, and in their team, they have 6 persons in charging of this patient navigator program. They have a psychologist, they have nurses, they have doctors, so they have social workers. So they are really keen to adopt and, if possible, to become the future trainers. Yeah.
Well, congratulations on this great effort. You've done a lot of thinking through this, and I think patient navigation is a very hot topic. Even in the US, it's a big part of our moonshot. I would challenge you, and this has already been brought up, I think Melvin and others, of how are the navigators long-term, not short-term, going to be covered? How are you going to convince your ministry that this is efficient, it's worth their time? If you want to move this beyond Sarawak, beyond Cancer Research Malaysia paying for the navigator, what are you going to collect that will then take it and say, look at how much more efficient it is, and look at how much better outcomes we got, so that the next area you go to will say, this is worth the salary. So number one, think about what you want to do with what you're collecting to convince other settings that the navigators are worth the time and effort. I think you can do that. But number two, I think that this was also brought up. I do think as you roll this out, you should look at how the different professionals feel that the use of their time in this is used, the efficiency. These are, a GP has tons of other diseases to worry about. So to ask them to do 4 full days in a year, and then once a month, 1.5 hours, and they also have to worry about kidney disease and heart disease and all this, and you're only doing breast cancer. What's the efficiency at the GP level? And then how are the specialists reacting when, if most of these patients are coming in with a breast lump and it's not cancer, are they not being used efficiently? So I just challenge you to look at the efficiency of it, and I think the idea of creating a specialist maybe in the GP, that if there is a breast lump, that you've got a core of people that you can refer to. So I just challenge you to collect how people are reacting to it. Is this efficient use of time? And then number 3, I'll just throw out, I'm sure you're aware of this, but the WHO has launched this Global Breast Cancer Initiative that has a set of metrics on 3 major cores. One is, what's the time from the symptom to the diagnosis? What's the time from the diagnosis to initiation of treatment? And then what's the completion rate for the treatment? Use what the WHO is doing, and to make your case when you go to your ministries and when you go to your doctors and convince them of it, because it's a big ongoing effort on the part of the WHO. And so this fits right in with it, and I heard you mention some of the metrics you might look at, but why don't you use what WHO was already promoting?
So great comment, and I agree. So we have identified some of the potential impact measures. Again, the idea is to involve the group identifying those impact measures, because we might be missing something that they will come up. But yes, the ones we come up are quite overlap with the ones you mentioned. I think time, so the referral time, so time from GP to specialist, time for cancer diagnosis, and time for treatment. That was our initial. Then, of course, to convince, I think I'm going to take your question further. So to convince for example, health minister. So the idea is really to implement a pilot study, which was properly and very, we took a year to think about why Malaysia, why Sarawak. So we're very specific because we want to make it work, right? And then the idea is to, on top of those impact measures, to add health economics, to really show that, okay, all these measures, in fact, translate into like saving money for the country. So that's one of the ways to convince, because the idea is, in a short or midterm, is to use the resources we already have to support the collaborations, that will lead us to, like, with that we'll be able to develop the pilot study, get data, and use that data to convince. That's one thing. Then your second question regarding the time, right? Time right now, it's probably the most important thing that we have. So I fully agree. So during this year, we had the opportunity to interview important GPs in Malaysia, also medical oncologists, and everyone seemed very, very interested. I think the idea of having one champion in each GP practice, or the way they want to organize, we thought about it before, but we didn't want to impose that. But I think that could be a good solution, instead of just making everyone do the same and then they have a small fraction. If we can, within the GP practice, to say, okay, if we have a cancer patient goes to that GP specifically, makes everything smoother, faster, and more efficient. So great ideas. We can definitely implement those in our program. Thank you.
Well, may I use time for any questions?
Yeah, can I ask?
Yeah, sure. Please go right ahead.
I'm not sure whether they have covered this topic, because I went out for a while. Well, if your project, congratulations on the presentation and great project. If, let's say, your project is successful, you have GP champion, you have patient navigator, you have support from the hospitals, etc., and then the diagnosis to the time of initiation of the treatment is shortened. Have you ever thought about patients and the patient's characteristic? Because you know, Malaysians, we are, I mean, I'm talking about Malaysians, we are on this shy side. We don't go to doctors regularly just to have the breast checked when we're talking about breast. And most of the patients that come to the hospital, normally they are on the urban side of the population. They are not in the district or rural area. And knowing Sarawak, they only have a few big cities, and mainly the population stay in the district. So have you thought on how to reach out to those, not in the patients, not in the, because you have we are talking about doctors, navigators on the other side, not on the patient side.
So during the interviews, we get to know a lot of people expanded to the GP level, also try to reach out to the community level. So Lubang project is already know what this situation, so they thinking about the reach out to the leader of the community level. So they know why patient is so shy. So they understand the situation. So they find the way. So also during the interview, so I'm very deeply moved, because it's a lot of, because of the healthcare personnel is so pure, I know. So, but I get to know I have no doubts, because it's my friends is working so hard. Everybody's doing their job very, very enthusiastically. So I think no doubts right now. So.
Yeah, for the reaching out to the community, that is the phase 3 of Cancer Research Malaysia project. So the phase 1 is tertiary hospital, phase 2 is district hospital and primary care clinic, and phase 3 is to reaching out to the communities. So they have actually started some of the program which they goes to the community, they train the community women's how to do self-breast examination, and they bring this group of women to another community to share their experience. So this works will be done by Cancer Research Malaysia. Yeah, for our proposal, we couldn't cover that large. Yeah, but this is a very valid situation that we need to reach out to the community. Yeah.
All right, may I have questions? Yeah, congratulations. It's a very interesting model for cancer care in the future. I have a question that I'm not for sure that in Sarawak pilot, do you have any problem for long-term waiting to get investigation, for example, mammogram, or like long-term waiting to get a tissue diagnosis? Do you have problem like that? And do you think this model is going to help for shortening time of, like, for waiting to get investigations?
Yes, we are facing the same problem throughout in Malaysia in the government hospital settings. So for this patient navigator program, they are setting up Pink Ribbon Center. So once they pick up a potential breast cancer case, they will facilitate the mammogram, the triple assessment, to be done within 2 weeks. Yeah.